I'm sending my regards from Serbian Gynaecological Society, as I'm a president of the society. So I'm very glad that I'm here among of us, all of us. And let me put straight to one specific part, that's such as low-grade serous ovarian cancer, and just to show you how we implement all this multidisciplinary. Nowadays in gynecology or in oncology, we can't deal by ourselves because we need to do multidisciplinary, starting from our colleagues, pathologists, molecular biologists, because it's not just to diagnose, operate, and then what to do. So how is going on with this very particular low-grade serous ovarian cancer? We know that ovarian cancer is very, very, very difficult. And nowadays we know about this dual classification of type 1 and type 2 and heterogeneity of ovarian cancer. And we will specifically find some interest in low-grade serous ovarian cancer because there are some differences, such as in a histological, in a clinical way. I will not dig in histological because I have a pathologist, so I don't want to wrong something to say. So and also we have particularly some gene and molecular mutations and problems and differences between these types. And knowing about all these things, how we can nowadays implement these findings in the clinical situations. So speaking with low-grade sarcoma, is often bilateral, fine papillary growly, and the first interesting is comparing with high-grade ovarian cancer, which is frequently most found and diagnosed in ovarian cancers, that it is estrogen or hormone positive. And very high positivity of estrogen. It looks like something like the breast cancer or a little bit like borderline. And if you look at overall incidence, it's really rare. So in this table, just comparing, we can compare some differences from the two types of ovarian cancer. Origin from ovarian. So low grade frequency is very low, up to 10% comparing to high grade serous ovarian cancer. But also, as we see differences also to notice, it's found in the younger patients. CA 125 is not so specific in this group of the patients. What is the most important is the options about the chemotherapy. This group of the tumors are not chemosensitive, such as high-grade serous ovarian cancer, but still, empirically, we are treating these patients such as high-grade with chemotherapy, mostly adjuvant. Also, if we are looking, they have the bad median overall survival because the growth is slowly. And also, if we see the gene mutation reported, we are dealing with some about the BRAF, KRAS. It's much more expressed than in high grade, and totally opposite comparing expression of TP53 and BRCA. That is very interesting for this group of the patients. And these are also some differences on pathological examination. I mentioned that I'm not pathologist, so I believe to my colleagues that they send me, it's low grade, it's high grade, okay, then I have to do what to do with that. Concerning the low grade and high prevalence of activity, somatic mutation in mitogen activate protein kinase pathway genes. So they found it in KRAS, BRAF, and NRS. found expression. You will find it from 10 to 30%. Even if they dig a little bit more in these exons of these genes, they find some interesting of expression in some of these codons you will find over there, such as G12Y or G12D for up to 50% in KRAS, and BRAF is much more in V600E. What is interesting is also that these findings can be the only predictive factor. That they found that KRAS G12V mutation is associated with significant worse prognosis. If we also look at all these differences, you will find slight mutation also in colon cancer, thyroid cancer, and breast cancer. So, we start with diagnosis of adnexal masses. I'm not so sure. I found that the next speaker will be about the radiological nuclear findings, so I will not speak a little bit. But I'm not so convinced that we have some specific tool, radiology, CT, MRI, PET-CT, that could show you a sense, yes, this is the low grade, high grade, even serous borderline tumor, because they look on radiological a little bit the same. Always I found on the report of the radiologist, I can't exclude malignancy. But what is the meaning? Because if I have adnexal mass and the sentence, I can't exclude malignancy, or is it even by ultrasound finding, comparing the IOTA classification, that is some problem with the malignancy, or I have to go inside the abdomen to see what's going on. Of course, there are some little differences, but I'm not so sure that my good colleague radiologist sent me, yes, this is the low grade, this is the serous. I need pathologist for that and to find it. So how we deal with this adnexal mass, even if it's shown that it's low grade in frozen section, whatever. So, of course, the cornerstone of the treatment of ovarian cancer are the surgery. The most of the ovarian cancer, high grade, even this low grade, are diagnosed in advanced diseases. So the cornerstone is cytoreduction or debulking surgery. The most, this paper shown that without macroscopically disease had a better PFS over survival. But in this low grade, this saw that also comparing the high grade, if you leave the lesions 1 to up to 10 millimeters, also you have that benefits. Over the 10 millimeters, it's you don't have not good prognosis for them. Also in this paper, you will find some factors predicting progression-free survival, such as advanced disease, Figo stage, and also residual. But the residual more than 10 millimeters. In conclude, the author said is that the cornerstone is clearance and optimal debulking surgery, but also the benefits and PFS over survival is also in patient with 1 to 10 millimeters. So this is the one parameter difference from high grade. What we'll do next? Adjuvant treatment. So empirically, we treat the same. That is that we don't know how to do it. We do the same with chemotherapy. Standard treatment, Taxol, paclitaxel, and a platinum-based regimen. But we looked at the studies and find in retrospective analysis of meta-database, including more than 5,000 patients, that is the reference is very nice, that find the response rate to chemotherapy after suboptimal debulking surgery was lower in patients with low-grade serous ovarian cancer compared with high-grade. In 2 different studies also they confirm some PFS about 11 months and double decreases in Gerhardson studies, GOG 028, one was found just PFS 7.2 months. But in that study, authors conclude that the more, comparing to this Milo study, was the heavily treated patients. In ovarian cancer nowadays, increasing the treatment with neoadjuvant chemotherapy. High grade I'm talking, and also how to do it with the low grade sarcomas. There was an interesting recently published paper. Even neoadjuvant treatment, we know in high grade ovarian cancer did not show some benefit in overall survival, but still increasing in the world because the morbidity postoperative is much better, optimal debulking interval surgery is higher in this group patient. But in this group of the patient, this recently published patient that took only using the neoadjuvant chemotherapy in low-grade ovarian sarcoma, clear cell and mucinous, not high-grade, found that using the neoadjuvant treatment in low-grade ovarian sarcoma is worse for prognosis. Worse prognosis, not good efficacy, it's the same efficacy, it's worse prognosis. So the primary debulking surgery is the cornerstone in the low grade. They've shown in this very interesting paper, low grade sarcoma, low grade serous, sorry, not sarcoma, so grade serous. I'm showing 1,156 patients. So it's a respectable number. Also, they tried to use in that paper meta-analysis that show hazard ratio 2.1 if you use neoadjuvant in low-grade ovarian cancer. What about the BEV? Because the bevacizumab is the standard of treatment in ovarian cancer. Yes, they found in this patient, they found that adding the BEV can be do good in the low-grade ovarian cancers, even if you see this in the corner of the graph, you will find that using the BEV in optimal debulking and this in debulking with up to 10 millimeters is good to use the BEV, even in recurrent disease. So, can we personalize the medicine? Can we targeting the treatment of low grade if we know something and we know the pathway of the problems, and we found the pathways of MAKP, hormonal treatment, because the expression of estrogens. Can we use this group of inhibitors of MEK, of BRAFA, or hormonal treatment to maybe change the policy of the adjuvant treatment to change with some other drugs than chemotherapy? And these are groups find that in the clinical management, these are the starting with the treatment of adjuvant hormonal treatment of low-grade sarcoma. They found in the good progression-free survival if we use the hormonal treatment as adjuvant, and also in overall survival. Feder in 2017 showed excellent recurrence and survival rate using surgery and the hormonal treatment in primary setting of 27 patients. And these developed the all other study with using the hormonal treatment, starting in Paragon study. It was interesting that recently they found progression rate and clinical benefits rate of 64%. So it's very interesting. And for me, that will be the most interesting trial is phase 3, this NRG GI-019 that will look about observing the carboplatin paclitaxel letrozole maintenance or letrozole monotherapy in adjuvant treatment. So this will show us maybe that we could change the adjuvant treatment from chemotherapy to something else, much more efficacy. These are some studies that show the combination, and recently published in SGO in 2023 abstract about the letrozole ribociclib as inhibitor of cyclin D1D, CDK4 and 6. They found a good response. I will not go in details. The median time to response was 8 months, and in 64% of available patients, expression reduction in target lesions, and progression-free survival was 90%. If we compare, there was no some new signs of toxicity, and if they compare all other trials, these trials can lead to the very good, not inferioric treatment, as in PFS, SD rates, clinical benefits, as you saw, comparing to the other. MEK inhibitors also shown, tremantinib also comparing to the standard of care. So a little bit we are thinking about using these drugs. Unfortunately, they are expensive. I don't know how we'll go in the clinics in small countries. And also MEK inhibitors with combination of some of these other combinations. So using the hormonal, as these are the knowing pathways of what's going on with the gene mutation and how is going the developing of tumor cell proliferation, differentiation. So looking these pathways and try to affect and did it to change, because we know that chemotherapy has a very high toxicity, and it will be very interesting even in this case of low-grade ovarian cancer, that I think that I convinced you that there are change and there are different of high-grade ovarian cancer, and we can't treat it the same way, only the surgery. So to conclude, our understanding of low-grade serous carcinoma has changed dramatically, as we have distinguished them as a separate entity from high-grade serous cancer. Surgical cytoreduction remains the mainstream of the treatment when feasibility. Low-grade sarcoma is in general chemotherapy resistant, have to think about that. As we show, neoadjuvant show no benefit, try to do the surgery before adjuvant treatment. There are varieties of promising treatment of low grade, so these are concentration on 4 different pathways in CDK4/6, MAPK, PI3K, mTORs, and endocrine treatment. And all that happened because we entire society, community make together to register as a GYNOCARE politics shown, that we have together the registry as for this group of tumors, that we have connections, multidisciplinary approach, and only on that way we could do the randomized trials, let's say, because we have to think that these are rare tumors, and one facility, one institute, or one country cannot do nothing with several cases. So we need the approach for the registered and future management for low-grade serous ovarian cancer may be personalized therapy management with the integration of molecular pathways, basically on these target therapies, endocrine therapies, and of course the surgery as the cornerstone. So please welcome to the European Capital of Culture of Novi Sad, because I'm from Novi Sad, the Institute of Oncology. So please welcome as a tourist, not in medical way of some congress. Just come to see the Novi Sad. Thank you very much.